one of your hosts, Dr. Melody Boudreaux Nelson, and with me today is my friend and colleague, Dr. LaShanta Bryce, UTMB DCLS graduate, co-ed specialist extraordinaire. And today, as promised, we are kind of doing a part 2 to the DCLS chat that I gave a couple of weeks ago. This time, however, Dr. Bryce and I will be chatting about how the DCLS is a degree and not necessarily a job title, and kind of where that has put us in the landscape of healthcare integration. So, Dr. Bryce, welcome to the podcast. Thank you for being here.
Thank you for inviting me.
Always. So why don't we just kick off with you really giving me your thoughts on what it means to say that it really is a degree and not a job title.
Well, I definitely agree with that statement because in the very beginning, there was no job description that even included the DCLS as a qualifying degree. So one of the first things that happened to me when I was employed by an IVD company was I had the chance to go to a conference and describe what a DCLS practitioner is. And a lot of IVD companies that were looking for scientific affairs individuals were very impressed with the degree and the rigor of the degree. They just didn't know about it. Nowadays, it's not as frequent as we would like, but at least there are some positions that now have the DCLS listed in the IVD sector as a qualifying degree. So we're making progress. We're hoping in the future that it becomes an automatic choice. I know that in my field of coagulation, it will definitely be a choice here coming in the future, but we're hoping that it spreads to all disciplines pretty soon.
Yeah, I think it was similar for me in that we only have a role at the institution of like PhD practitioner. And so having a clinical doctorate that wasn't that, if it wasn't a pharmacy degree, like wasn't listed. But I'm grouped in with the PhDs, right? Because it's a clinical doctorate. And even though I'm not. And so it's an interesting thing. Do you feel like it's perpetuating some confusion still for like how the lab medicine community in general sees DCLS in practice? Or do you think it's just like another aspect of people not understanding?
I think there is some confusion, specifically in the core lab disciplines, because traditionally it has been a PhD, and that's also true over in the IVD sector as well. I think that once we get more practitioners into the field, that confusion will lessen. And really, the people that are confused probably just don't have knowledge about the DCLS as the degree, and certainly that leads to less knowledge of the DCLS as the practitioner. So that's something that employers have to kind of differentiate themselves. And as we publish more information about the DCLS, that'll help us out quite a bit.
So what did it look like for you when you were entering the field and trying to carve out a professional space for DCLS with your skills?
So I was actually soft recruited. And what that means is that I had some individuals that were looking at me for various roles within the company prior to me graduating with the DCLS degree. And one of the reasons why they took interest in me for specifically scientific affairs was because I was forward thinking in trying to replace my brain on the floor. So I wanted to adapt a lupus anticoagulant algorithm from Belgium onto an electronic system. So after I made that request, almost all high level people came to see me at the hospital, and I just wasn't aware of why those people were coming. I thought they were just coming to help. So I actually wanted to go to the technical services department first, and their central line manager came down from Arkansas and said that she would rather refer me to scientific affairs to give me a better opportunity to grow within the company. From there, the actual job was already created, but it was written for a PhD that probably doesn't actually exist in a normal setting. They wanted a PhD that had bench coagulation experience to include management, workflow processing, and SOP creation. So that sounded very much like an MLS that had an advanced practitioner degree. So when I interviewed, I was interviewed in a round robin with scientific affairs and marketing. So that is how I created the space for the DCLS. And once the upper management found out what the DCLS was, they're like, we should have known about this the whole time.
Yeah, isn't it interesting how sometimes what people are looking for already exists? You know, we
Yes.
just needed the space for the advancement, right? The career ladder within a medical laboratory scope. Because I mean, I hear a lot of conversation of like, well, you could go into pathology, but that's not necessarily what we want to do, right? And that's not
No.
who we want to be. It's not for us not being smart enough or not like wanting to do that work. It's that our lens is different. And I think that's a very common misconception. Um,
Yes, it is. Like I've heard lots of times, you're so smart, you could have went to medical school. And I find that comment a little bit, not a little bit, a lot of bit demeaning, because it diminishes our scope of practice as a scientist. In reality, anywhere where there's medical laboratory science being practiced, there should be a medical laboratory professional. And at this point, acting as the bridge between pathology and other avenues seems to be the best fit for the DCLS.
Yeah, I find myself in that lane a lot of just being the conduit to get to the right individuals. You know, if physicians know who to ask for, they
Yes.
know your face and your name. Even if you're not the person, they know that you'll help them get to the right person, and I think that that's been a lot of my effectiveness in my role of just um, getting to know people, like and having that conversation, and then but I also think it's challenging because when you think of a nurse is a nurse, right? You get a degree in nursing, you have a nursing job. You're a pharmacist, you're a pharmacy major, you're a pharmacist when you get into practice. Like, do you think in the long term it hurts us to not have roles defined in healthcare by our degree as is commonplace? Or do you think because of the diversity of our backgrounds, it's actually a benefit? I think it's a mix of both from my perspective. So I'm interested in your perspective.
I think that if you're looking for recognition, it's still going to be difficult because when you think of the traditional role of a scientist, it almost is the public's opinion that you're describing a basic scientist and not someone that works in a clinical laboratory. Of note, we kind of put ourselves in this position when all of the professionals decide to call each other and others different names within the medical laboratory profession. So
Amen.
once we are able to shift us over to a standard nomenclature, I think that can resolve, and then that will help the DCLS solidify what we can be called. But I'm okay with the term a scientific practitioner. Now that is hard for public facing people, like those that are not in healthcare, to like recognize. So I oftentimes tell family members I'm a scientist or a clinical scientist, and they're like, okay, I can remember that.
I'm like doctor of lab med. I say that a
Yes.
lot. You know what I mean? Like something general. And honestly, because I'm boarded, I introduce myself as a clinical chemist. I mean, that's what I do. I don't even because that in my field is like what's recognized. Do you know what I mean? Like
Yes.
everybody knows what a clinical chemist is. Like, and I don't have to explain that as much. And so if they ask like where I went to school and what I did, like I'll elaborate. Um, but I do think it makes it hard for us to find each other sometimes too as a DCLS community. Um,
Yes.
that's challenging. And also, I think for people to understand, like, we are working and being effective.
Yes.
What is your take on, like, have you encountered that where people kind of just don't know that there's DCLSs in practice because they just don't go by DCLS?
I think so. For me, it's a little different because I travel so frequently. So you and I actually met because I was
Yeah.
traveling somewhere.
Yeah.
Um, so I think for others, it's hard to find community because we don't have a standardized way of noticing when someone is working in a specific position. So some of us are called lab directors, some of us are called medical directors. There's always kind of the fight back and forth which one you should be called, and that's really institution specific. I don't think that's going to really change with the introduction of a new practitioner, but I do agree that, not having that standardization creates a harder way for us to get a community built where we can exchange ideas and, just basically be friends as practitioners. But it also hurts us where we can't rely on one another unless we've actually crossed paths somewhere. And for me, I'm very lucky to be able to run across the United States and Canada and happen to run into practitioners, but
Yeah.
that should not be the case for everyone else.
Yeah, it is hard to kind of run into each other or meet each other. I also feel like we're very siloed in our institutions and what we're working on. I think um, what's interesting about the DCLS is that people come into it in different places in their life and in their career journey. And that also, I think, has attributed to some of the diversification of the
Yes.
end result, which also creates some, I think, confusion or just in general, like some of these generalized comments that are derogatory toward the DCLS. I'm like, well, there's not enough people doing that. It's like, well, there's not a ton of people that want to do chemistry or that want to do coag. Like
Yeah, that's
MLS
true.
is unique in that way, you know?
Yes, there's deficiencies in in clinical pathology and in pathology in general, actually. So it should not really be a shocking thing that you see that there is a deficiency in a blooming program. We have to just graduate enough people first.
Yeah. And I mean, what's interesting to me is like there are a lot of people applying for programs. Like all 4 programs have full classes, which is pretty cool. Um, but they're all different scientists with different backgrounds. And I think it's just, they're all going to have different ways they want to use it too. Like I was very clear on like what I wanted to do and how I wanted to use it. Do you feel like you were in school or do you feel like it developed afterward?
So I think I was very naive in thinking that once I graduated, that I could just change the world. So my intention was to begin to change military medicine because that was my background. However, given the amount of red tape within the military medicine community, we would need several practitioners that were working towards a common goal to create that type of change. I think I really wanted to make sure that military families received the same equitable care that you would get from a civilian entity by using things like correct workflows and making sure you had better test utilization because unlike the civilian entities, you could just pretty much do what you want. So there is no such thing as over or underutilization to them. It's just a good environment for you to test things, but then if it goes unchecked, does it lead to patient harm? And what we found out was that yes, there is some patient harm that's going on, but we need more than 1 or 2 practitioners to try to correct that.
Yeah. Do you find that there's space um, when you're talking to individuals, just space in general for like, and I want to say like in their heart, but in their mind and in their heart and in their workplace for DCLS conversation? Because there is still dissenters, right? People who really are like against it and don't even want to like move the needle. So I'm wondering what your perspective is on that.
I've seen that not only in institutions but in professional societies. I've seen where there's a lot of dissent, but then I challenge them gently and say, when we are at these professional society meetings and I have people lined up to ask me questions about coagulation, I think you need to ask yourself if I am an expert enough to answer your questions at your institution, why would you not consider me an expert as a lab director or just as a practitioner? And then that kind of causes them to self reflect. Where is the dissent coming from? Is it actually just because you're not knowledgeable about the practitioner, or is there a dissent because you are afraid of being challenged?
Yeah, and I think there's this idea that especially with the boards, like, well, they all want to be boarded and they're all going to, like, because they just want to take our jobs or our money, lab directorship money and that kind of thing. And I'm like, first of all, it's not that much money. And second of all, especially on the CP side, like, we are not paid like an AP. Let's just throw that out there. And there's different pay scales for people with clinical doctorates versus people with MDs. I mean, that's just like a thing, right? Like, it's more so, at least from my lens, what I've really tried to stress is, like, most people coming out of school get their APCP training in case they end up in like a rural facility or something, like, not because they're passionate about CP medicine. Like, there are people who go to pathology who are passionate about heme and coag and clinical chemistry, don't get me wrong, and microbiology, but there's a reason PhDs are in the micro and chem space, right? There's just not enough, and it's nuanced, and there's things involved. And so, like, we have to stop acting like, for some reason, everyone knows everything. Does that make sense? Like, physicians don't know everything, and I don't know everything. Like, that's just how it is. We all need each other in a diverse field.
Yes, that's why the sense of community becomes very important. And I don't want the listeners to think that I'm trying to create a sense of community for DCLS practitioners only, like a keep out sign of everybody else, but more so that we build a community within ourselves first and then spread that community out so that we create the bridges that patients need for healthcare, right? Because certainly my own world has both CP, AP practitioners on it, PhD clinical chemists. It's a very diverse field, and my own group has that diversity for that reason because I don't know everything. I do not claim to replace a hematopathologist. In fact, I called two of my hematopathologist mentors and my former blood bank director here recently because I had a issue come up and I did not think about the downstream effects to other sections like transfusion medicine. One of the things that becomes very important for those that practice coagulation is that you are not a sole entity. You actually can, greatly help a section or you can harm it. And in the case of transfusion, think of transfusion as a cousin. You are supposed to always be thinking about that and having someone in your back pocket that can help you answer questions. Because I'm not an SBB. I have not done any blood bank since I left the DCLS practitioner school. So definitely anything that is complicated transfusion medicine, especially workflows, you do need to reach out to your community to help you with that.
I love how you said that, right? Like, we're not trying to alienate PhDs. We're not trying to alienate pathologists or MDs or anybody else. Like, we really respect all of these people we're working alongside, and we understand, like, where our niche is, versus like where their niche is. I myself have a PhD clinical chemist mentor who has been in the field for a long time and knows a lot, and there's a lot that I can learn from that individual. And they also, because what I find interesting is because they were on the PhD path and experienced a lot of the initial blowback from MDs when they came in, is very sympathetic and very empathetic to like where I may be at, depending on where I'm up against. And it's like, hey, let me tell you some lessons I learned, right? Like, this is how I navigated that. And here's some tips. And it's just so helpful. There is a community of people who want you to succeed in your passion, because at the end of the day, it's about the patients we serve and we care for. So yeah, I don't know, like, but I would encourage DCLSs to seek that out. I love that you highlighted that. Like, you don't come out of school knowing everything. You don't work 10 years and know everything. It's just an ever changing field. So
if you find the right sense of community, then you'll easily be able to exchange ideas. And once you open that door to the community, then they will shoot questions over to you, right? There have been lots of times where I've gone into those hematopathologist or the blood bank director's office and had very deep conversations about workflow, about experience from both the patient side and the laboratory professional side to help them understand why certain decisions have to be made. This is also why even here in the IVD world, I've now started a laboratory advisory board to make sure that we see both sides. We see the clinical outcome side, but we also acknowledge and very much look at the workflow side because that ultimately is always connected to the patient. You can always approach a center point 16 different ways, but one of those ways is probably the best way. And the only way you can figure out if it's the best way is to actually use your community resources.
Exactly. And like what I've learned, when you're an MLS on the bench, like your perspective sometimes of what's happening outside of your little realm is very limited, and you don't always, you might get yelled at by a physician and be like, oh, I hate that department, right? Like that's just, and then you like walk
Mhm.
away with that. Whereas like where the DCLS and the education and the residency piece was so impactful for me, as like I got to get out of the lab and like see what they do, talk to patients, like
Mhm.
see them in their element and watch how good they are at what they do, right? And it helped me gain respect for them. And it really helped me understand like where we actually intersect the workflow and like why that call may be happening. And it was just a great exercise.
Yes.
And like mind bending a little bit, but also very, very impactful for me. Like, did you find that in your residency experience? Like, did you get the same thing? Because you were a different program than me. So, like,
Yes. So residency was very shocking for me. And I'll say that with a small caveat that remember, I come from a military background. So my perception of healthcare looks very different than most people. So for me, not being in the military environment was very jarring for me because now I'm going into an environment where insurance matters, where caseworkers are intervening.
mhm.
So for me, I learned how medicine actually works, right? Because before I am a participant in medicine, but I don't necessarily know how it works. You give me an order and I do it. And I don't really question why the order is in this specific order in the first place. Now I can kind of see why we have gaps in healthcare
Yeah.
when we're in a rounding team and you're the patient and you don't have the DCLS student on there. That is a little scary because your ability to order labs that are efficient depends on the collective knowledge of medical students, interns, and fellows, maybe the faculty, but at that point, the faculty sees it after the group has done it. So it's almost like living through a Grey's Anatomy in real life. That's how I describe residency. I was like, oh my, this is a lot. So what it did is it actually changed and morphed how I would practice even as an MLS because I'm like, wait a minute, is all of this stuff happening on the outside? I didn't know any of these things were happening. Well, I knew to like a 30,000 foot level things were happening, but I did not see the actual like lines of how healthcare was happening.
Yeah, where we intersect is such an important piece for us to understand as laboratories. And like honestly, I think it's where I began to understand like value-based medicine and like some of the things that I'm passionate about now and like where can laboratory medicine integrate is because of that residency. And seeing things like I literally had a physician on rounds one time be like, "Hey, you're with lab, like why don't we have this test? So and so has this test. Why don't we have this test?" And I'm like, I don't know, but I could find out, like because we had the instrument to do that test. And it's like, oh my gosh, guys, like they want this. Like, and it would help them triage their patients sooner. Why we're not giving them what like we really got to have a conversation in the lab of like, hey, we can be a better partner, you know?
Yeah, I think that that highlights the part where oftentimes when I give educational presentations or seminars, the first thing that pops out is the introversion of the laboratory.
Mm-hmm.
But if we are to act as a partner, we have to be able to come out of that space, which means when there are opportunities for laboratory representation on a committee, please volunteer because that's one of the ways that you can find out how you can better service your patients and ultimately the rest of your colleagues. The rest of the practitioners in the hospital are your colleagues as well. It's not just the people that live inside the lab with you and the patients. We actually are colleagues with several other individuals.
Yeah, that's always been my like. I like how you say you push back on like why are you against this? I always push when I like get people who dissent. I always push back on like, well, you've had a long time to get out of the laboratory and be a bridge, and that hasn't happened. And look where we are. And so like, why are you against individuals who want to be a bridge? Like, why is it a bad thing to have a role that interfaces with the rest of the healthcare system, including patients? You know,
Yes.
why is that a bad thing? And like, why are you against that? Like, that should be something you're excited about, especially as we look to value-based medicine, that we have a face and, people feel that we're approachable. So that can prompt some self-reflection as well. But, you know, it's just,
You got to come out, guys. It's
yeah,
a thing, guys. We have to come out of the laboratory. And
we
yes, I
do.
was okay in the beginning, and I was only in the laboratory like without coming out of the laboratory for a good 6 months. And
Yeah.
then right after that, then I started doing bone marrow bedside assist, which drew me into the medical laboratory scientist that then became the DCLS. Because otherwise, if you don't have those experiences, you think everything is a number. And you can certainly you can make decisions based on numbers, but is that really best value care for your patient, and is it safe? Sometimes you need a little bit more information about the number, like what happens when I have to have a caseworker. I remember the blind sickle cell patient I had in
Mm,
internal medicine, and not being able to do her fine needle aspirate, because she had the wrong form of insurance, for outpatient care. So her story was she needed to be driven in by her 14-year-old granddaughters. If I just saw her numbers, I'd be like, it's fine. She can get it done outpatient. I was like, not if she can't get back to the hospital because it is illegal for 14-year-olds to drive. So,
you bring up the complexity of medicine, right? Like, it's not just like I think about that. I work on a lot of age-friendly things, and it's the same thing. It's like, is the afternoon really the best time to be doing older adult draws? Like, if they're 85 years old and they have dementia, like, is that the best time, to do an invasive procedure? Like, are we cognizant of that? Um, do we understand like what it means to work with patient populations, who may be experiencing sickle cell or maybe experiencing diabetes, or like the types of challenges? Are we sympathetic to that? Because you see a lot of things online, especially like you can use the paper TikTok viral thing that went around, or like, the thing now with like the patients who don't smell great or whatever. And it's like, that's just learning sensitivity, right? Like, it's learning
yes,
sensitivity to your patient population, and that those individuals obviously are on the learning path. But like, labs, sometimes we aren't exposed to those things.
correct.
So we're having to learn. Residency for me was a good place for me to like learn and practice those soft skills, like having a patient cry because their wife is next to them and they want to go home and pass away at home. Like, that was intense for me.
Yeah, yeah, that's one of the things that was corrected actually, because I was a very early entrant into the UTMB program. So there's really only one class ahead of me.
Mm,
So when I had my first set of patients, where I have termed this the death talk,
yeah.
I broke down in tears. And the rounding group was like, you know that patients pass away, right? I was like, yes, but that was a sharing moment, because for them, they think it's a human experience, which it is. However, for a laboratory professional, their perspective is very different on a patient's journey, into death. Because for us, we just see your samples stop coming to the laboratory. We acknowledge it somewhere internally, and then we move on to the next set of samples. Now I have to actually like figure out how to deal with it in person
Mm,
professionally. And sometimes some practitioners are really good at it, but it may also may be based on your background. I had not had a lot of people pass away in my family, so I didn't know what to do.
yeah.
It ended up in a 10-minute cry session, and they're like, the next person's room is going to be the same thing. I was like, oh. this is not this is not what I want to do.
Yeah. We're like, this is why I'm in the laboratory. This is
Yes.
why. But then at the same time, it's so good because like for me, it just helped me. And I worked trauma blood bank for a while in my career as a bench scientist, and so I had some experience with it from a trauma perspective, right? And like, but that's like I say trauma is always like quick and dirty, right? Like you're steering it and clearing it, and then it sometimes they die, and like you don't even almost have time to process that, right? Like from a blood,
Mm-hmm.
you're giving them like 14 units, and like hopefully you're okay, and then sometimes it just doesn't happen that way, and you may or may not know, right, as a laboratory person that's what happened, or the potassium gets super high, and you're like, oh, that's not good, you know what I mean? Or
Yeah.
you get DIC or something, and we know it means that the patient's on their journey. Toward their next chapter, whatever that may be, but like we don't have to physically like see that, and that is a skill set that I admire in our physician colleagues. Like I just remember being blown away by how well some of them handle those types of conversations.
Yes.
And with family and just explaining things. I'm like, man, that is soft skills that I need to learn. And they have mastered them so well. So yeah, lots to learn from other people, lots of new experiences. I guess I would say for DCLSs, like interested maybe, or people interested in the profession, like know that your clinical residency will challenge you emotionally.
Yes, and that you will need community again because if you happen to be in a group setting for your residency, that is most helpful because then you can also exchange scientific ideas and say, hey, I'm going to pass this patient to you. They're about to come to your floor. But more importantly, like when you need a place to go and someone that can understand where you're coming from, then that's where your classmates and community can become very helpful so that you don't suffer as a professional, right? Because it's easy to get caretaker fatigue much quicker for us because we are not consistently exposed to this. Whereas now we're going to get an immediate exposure and you may or may not be able to get through it without some help.
For sure. And just like learning like how complicated it is. I spent some time in a geriatric Alzheimer's clinic and doing some of their working with like a geriatric pharmacist and like doing those types of things and realizing like, oh man, like there's a lot,
Yes.
and you get a lot of emotions sometimes with that as well of like toward the family, because you're like, why aren't they doing this or why aren't they doing that? And it's like, you need other people to like help put everything in perspective for you because they're more seasoned.
Yes.
We're very black and white as laboratory professionals. Like we just are. We're like taught that way. It was just really helpful for me to learn that like medicine is not and never will
Correct.
be. Even though my QC data has to be, right? So like
Yes, that's also a learning moment for them when there is the downtime. You can chat with them and say like, ask questions about processes,
yeah.
and QC does come up like, why can you not release this result? I'll say because there is a large regulatory body that says I cannot, and I now can act as a bridge, right?
You're experiencing in the room, right? And then when you have both of those things in your head, you really can be an advocate both ways.
Yes.
Right. And do so with a little bit of social currency, which is so important because if they don't know who you are, they're like, well, why are you don't understand me? It's like, no, I'm really seeking to understand you. Like, I want to know. And I've been on rounds with you and you know that I know, right? Like we tried not to cry in that room together. You know what I mean?
Yes.
Like, or whatever, right? Like I've helped experience it. And it does give you like new ways to solve old problems, I think.
Yes.
Yeah, for sure.
Because at least when you act as the light towards the laboratory, then they actually start to realize that the laboratory is not a functional place that just gives out services, that it has real humans in it, and that there are ways that you can get something done. But they just need to know where resources are. And if you can be that first door opening, you can serve a lot of good, not only to the practitioners that are outside the laboratory, but certainly to your patients as well.
Yep. We are collaborative partners, not black boxes. You
Yes.
get nothing else out of this chat today. Well, I want to thank you for your time. I always love chatting with you and catching up
Yes.
and talking. But I really want to thank you for your time today and your insight and just your openness to discuss the DCLS. And hopefully we can do this again, talking about some more questions that people may have. If you're a listener and you have questions about the DCLS profession or things that you've read or any of those types of things, like throw them in the chat. Like and subscribe, and we will do our best to answer them. And well, I guess that's kind of it for the day. Is there anything else you want to sign off with, Dr. Bry?
Just know that while the DCLS is not a job, look at the job description, and it might just be a DCLS that they're talking about. They just didn't call it the right name. So don't pass up a job because it doesn't say DCLS, because if the employer doesn't know that a DCLS exists, you can be the first person to make them aware that we do exist as practitioners.
I love that. That's perfect. All right, guys, stay SUPERSTAT.
Bye.
Bye.